profile is in keeping with severe kidney injury. PR3 came back as positive. We don't have anti-GBM, and he's got multisystem disease, including his lung disease. So we've got kidney, lung, ENT, neuro, severe manifestations. So we need to be aggressive in the management here and try to salvage as much possible because he will end up with significant degree of damage. So the options that we have here is rituximab with plasma exchange, or use rituximab, cyclophosphamide and plasma exchange, or Cyclops and plasma exchange. This is all pure observation based on observational data when it comes to the combination, except when we look at the rituximab trial, when it used the combination of rituximab and cyclophosphamide. So the benefit of using this combination here is that he would have a much higher chance of achieving remission versus having a rituximab only. It's a PR3 disease, and we've got a neurological insult that happened there that I want to reverse quickly. So the cyclophosphamide is going to help from that end. And plasma exchange would be advantageous to salvage more kidney function given his elevated creatinine. So I would be going for that as an option for treatment. The Cyclops, if you choose that option with a plasma exchange, it's because of his PR3 disease is less likely to be effective. But the Cyclops for severe kidney impairment is a useful approach. So here is the KDIGO evaluation of which settings you would choose cyclophosphamide, which settings you use rituximab. Please note that in the rituximab preferred option, there is frail older adults. So you can use rituximab in these settings. Sometimes you come across colleagues who are worried about using rituximab in someone who's elderly. It's designed, it is perfectly fine to use in that situation. Patients with elderly and having ANCA vasculitis, they do carry a higher chance of events happening and complications, but that does not mean that you can't treat them with rituximab. And on the cyclophosphamide side is typically your patient that we refer to using combination of cyclophosphamide and rituximab because of severe disease. So even in KDIGO, rituximab infiltrated into the cyclophosphamide preferred site. So it's everywhere for the management. So we mentioned plasma exchange in this patient. When can we use plasma exchange? Plasma exchange helps in getting disease control in life or organ-threatening situations. So in this patient, he's an elderly patient with progressive decline in functional capacity over 4 months. He's got edema and presented to his primary care physician, was started on antibiotic after they've done a urine dip. He was completely asymptomatic and was treated for a UTI. He presents again after 3 weeks with worsening swelling and breathlessness, and he has hemoptysis. His creatinine has gone to 520. He's still got the active urine sediment, and his immunology screen comes back as showing MPO ANCA. He's negative for anti-GBM. So should we give plasma exchange here? So we have a situation where this is organ-threatening and life-threatening, so it's perfectly plausible to use plasma exchange. We do have a risk of infection when we use plasma exchange, but it's justifiable by the survival advantage that we're going to gain, particularly if we have hypoxemia with hemoptysis and also the chance of better kidney function. So if I would modify that a little bit scenario and compare other patients, here we have the same profile, but we don't have diffuse alveolar hemorrhage. Suppose that we have this as a patient A, and we've got significant degree of kidney impairment. MPO ANCA positivity. Should we exchange or not? He's 75. He doesn't have diffuse alveolar hemorrhage. And this scenario B is a patient, he's 68, diabetic, and he's got creatinine, his GFR is 43, creatinine 150, he's PR3 ANCA. I suspect you'll be comfortable with denying plasma exchange for patient B, but you'll be more keen on doing it on patient A. But let's look at the Pixivas trial and what does that tell us. So it was a large, one of the largest studies in ANCA-associated vasculitis, and we have 300, but it's not large enough, by the way. Still, there was lots of question after the trial that maybe there was a benefit of having a bigger sample size. Anyway, the short story is that there was no difference between in the composite of mortality or end-stage kidney disease in those who had plasma exchange versus no plasma exchange, i.e. they had just steroids and standard induction treatment. The low dose, as we mentioned, low dose was as good as standard dose. So the trialists went back again to do a meta-analysis and combine all the studies done using plasma exchange in ANCA-associated vasculitis, and they published this in BMJ to include certain selection of patients who might benefit from the disease. And the conclusion was that if you can bargain your risk of infection for the risk of better kidney survival at 1 year, then plasma exchange would be a suitable option. For example, if you have a creatinine above 300, 350, then plasma exchange is going to give you a better chance of kidney function recovery compared to no plasma exchange, but you have a higher risk of infection when you take that chance. So you can imagine if I would push the age higher and higher of the patient, that risk of the infection, for example, becomes, or events becomes more and more. So that's why you have to be careful when you select your patients for plasma exchange. The benefit for plasma exchange in terms of the kidney function would peak at 4 weeks from the initiation of the treatment. And in patients with pulmonary hemorrhage who have hypoxemia, they do benefit. There's a strong signal for those who would benefit from plasma exchange. So I'll just go back a little bit to the story of we can have more than one antibody to deal with. So this is our patient who we presented earlier on with a dual positive PR3 and anti-GBM disease, anti-GBM antibodies, sorry. We can have this combination of positive ANCA and anti-GBM or positive anti-GBM in ANCA settings. They are different from the ANCA. How is that? When it comes to treatment plans, remember these patients were not included in Pixivas. So these are patients who you should plasma exchange aggressively because they would have a benefit from the plasma exchange. So dual positives proceed with the plasma exchange as long as we don't have any other concerns, but it's a key part of the induction plan. Now, the next question is going to be, what else should I use in this setting? Should I use rituximab, cyclophosphamide combination? Should I use cyclophosphamide only with a plasma exchange? Or should I use rituximab avacopan? Is there a rule for avacopan in these patients in the dual positive? They were excluded from Advocate. The answer is based on small case series. Yes, there is evidence for use of avacopan in dual positives with good outcome. The combination of rituximab cyclophosphamide would be reasonable option. This is based on observational, center-specific experts' opinion rather than based on much else. Why is that? Because we have even smaller population when it comes to data on patients with dual positives, because as I mentioned, they are excluded in the clinical trials, and therefore you rely on multi-center data. For example, in this study that was published in KI a number of years ago, Stephen McAdoo looked at these patients with dual positivity, single positivity, and antiglomerular basement membrane. And their timing to end-stage disease, kidney disease, falls between the ANCA and anti-GBM. Anti-GBM worst, ANCA being a bit better. So they tend to have a worse kidney outcome than the ANCA alone, but remember, they are treatable. You can get more chance of treating them than an anti-GBM disease, but they are relapsing. They would behave like an ANCA when it comes to the long term. So make sure, unlike an anti-GBM setting, when you stop treatment, you don't stop treatment on these, treat them like an ANCA. And ideally, rituximab-based maintenance therapy would be a good option for these patients. So speaking about rituximab again, rituximab is better for maintenance. This is a key message. Let's go through this case, then we'll talk about the evidence behind it. So we have a 48-year-old male with MPO ANCA vasculitis. We have kidney, lung, ENT disease, and we completed induction treatment with rituximab, avacopan, and steroids at the beginning. Then the steroids were taken out of the way, and then he's been doing well. BVAS is 0. He's got a bland urine. His GFR is 90, so everything is good. Now we come to decide about the choice for his maintenance treatment. And should we just leave him and see how things would go? Should we just give him some treatment? If so, should it be with azathioprine? Or should we give him rituximab and continue the study of rituximab avacopan as we started? Should we give him methotrexate? His GFR is good enough to tolerate methotrexate. Is it good for maintenance compared to these other strategies? Or should we just wait and see how he behaves? If there is activity, then to treat. If we give him rituximab regularly, the chances of maintaining that remission is by far much higher than give him azathioprine. That comes from the Mainritzen trial. The Mainritzen trial randomized patients who achieved their initial remission into either having rituximab 500 milligrams on a 6-monthly basis versus continuing with azathioprine. And as you can see, rituximab was superior to azathioprine in terms of maintaining remission. And there are very few situations when azathioprine might be considered as an option for the maintenance therapy nowadays, because rituximab will give you much better control. So one of these scenarios is hypogammaglobulinemia, if the patient is likely to have more infections with rituximab. So that, as I said, is small number of patients would fall into this category, and availability is more of an issue when it comes to maintenance. Although it's, I hope it's widely available to continue with the rituximab. Now, the Mainritzen was a 3 trial. There were other trials also comparing rituximab, different regimes of rituximab. Mainritzen was 500 milligram base dosing. Ritaziram was 1 gram dosing. The conclusion is the same. If you go with maintenance rituximab, your chance of achieving remission is going to be better. And most likely the kidney function would be better with time because you would have less chance of relapses happening. So rituximab is the way forward when it comes to maintenance treatment. If you If you don't have rituximab, azathioprine is superior to MMF. MMF is inferior, and that was shown in the IMPROVE trial. So mycophenolate is not as good as azathioprine, and that's why in the trials azathioprine is used as the control arm. Now, this is an important topic of monitoring for disease activity because it can be subtle. So here we have a 56-year-old patient with PR3 ANCA, again, renal, lung, ENT disease, aggressive at the presentation. He was treated with avacopan, rituximab, and steroids, and you are catching up at 4 months. And there is ongoing ENT activities happening here. So we've got suggestion of some disease activity. The urinalysis showed blood and protein, and the creatinine is rising. So now what? What should we do? Disease active despite initial induction and early on at 4 months from the rituximab and is already on avacopan. What should we do? And you can confirm that by having a kidney biopsy, which is showing an active disease at this stage. So the options that we have based on the KDIGO guideline is for us to consider switching to an alternative. So you start with rituximab, you switch to cyclophosphamide. Don't retreat with rituximab. It's not going to achieve much in this situation because he's already had decent exposure at the beginning. Plasma exchange is not it might buy you some time, but it's not going to solve the issue. You need more B cell control, more reduction in the ANCA settings, and more immune suppression. And the plasma exchange might give you a bit of a honeymoon, but is not going to solve the issue for you. So it's better to go more robust. So Cyclops would be a reasonable approach here. If you give them if you give 2 pulses of cyclophosphamide, for example, it might give you a bit of remission, but you can tell that you are dealing with someone with a patient who's going to be frequently relapsing. So let's follow up this patient and see what happened after that. So we started the Cyclops, and after completion of the Cyclops, we went back on the rituximab, and now 9 months after that, so things have got better, but patients still got ENT symptoms reoccurring after 9 months from that presentation. And we've got MSK features. The urine this time is a bit better. Kidney-wise, things are okay. And PR3 ANCA has risen again. So we've got stable kidney function, but you've got someone who's relapsing again. So now what? What should we do? We already use rituximab. We use cyclophosphamide. We can add mycophenolate to rituximab. It might give us some control, but be ready for hypogammaglobulinemia can occur in these settings. And its benefit, while was an option to use in the past, we've got better options here. Belimumab, as you know, the BREVAST trial showed that belimumab did not increase chance of remissions. There is it was the negative trial, the BREVAST trial. So adding belimumab might not salvage the scenario. Retreat with cyclophosphamide, it is possible if you used, but don't go for the full Cyclops regime, and be careful that chance you are getting to your maximum allowance of the cyclophosphamide. So if you use that approach, you have a truncated course, not the full course. Otherwise, you'll be hitting the maximum. It's the 10 gram that you should not go above. Methotrexate is possibly going to help, but might not be durable, the remission that you achieve with that. Alternatively, you can use obinutuzumab. As you know, this is a new anti-CD20 antibody, monoclonal antibody. We've used it in patients in this situation, similar to this patient, and the patient actually achieved good remission with the obinutuzumab. It's more potent than rituximab. The dosing is 100 milligram testing day 1, day 2, 900, and then after 2 weeks is the second dose, so similar to rituximab. One of the theories behind the obinutuzumab that the OBIVAS trial is going to answer is that obinutuzumab achieves more deeper B cell depletion at the niche areas rather than rituximab. So that's that. And how can we monitor for the disease activity from the renal point of view? So this is a very nice study that was published in KI, and it's a collection of data from key trials of rituximab, improved MySick and Mindritsin. And essentially, if you have proteinuria, persistent proteinuria, your chances of poor outcomes of end-stage kidney disease and death is 3-fold higher than if you don't during follow-up. So this is 4 to 6 months from the induction when you check for that. If you have persistent hematuria, then the chances of kidney relapse is higher. So it's very important to monitor your patients for hematuria and proteinuria and address these risk factors. And for the hematuria, if they have hematuria, have a low threshold even to rebiopsy if you're not sure that the patient is active or not. So that's it for the ANCA and for the PR3 and MPO. For EGPA, you come across this less often, and the treatment is different, as we mentioned, because they tend to have more asthma phenotype, skin manifestation, neurologic manifestations. Kidney involvement can happen as well, mainly in the form of interstitial nephritis. And the treatment tends to be steroid-based treatment. Avacopan is a tempting one to use in this setting as well. But you have anti-IL-5 based therapies such as benralizumab that can be used in order to avoid steroid toxicity and control the disease a bit more. The trials with benralizumab did not include patients with active kidney disease. And it's reasonably safe in terms of you don't have much of risk of infections when it comes to the use of benralizumab, and often is better to manage it along with a respiratory clinic so that both aspects of the disease, the pulmonary as well as the kidney side, is monitored closely, or even better in a vasculitis clinic. Tezepelumab is a thymic stromal protein TSLP inhibitor that reduce airway inflammation and is currently in clinical trials in EGPA. We don't have the answer for that yet. So in this case, you can use steroid mycophenolate, but the chance of remission, of achieving remission, is low. Steroid cyclophosphamide is perfectly fine option because we have a food drop here. So we've got a neurological emergency here that you want to salvage quickly. So steroid cyclophosphamide would be perfectly reasonable to use. Rituximab might be delayed in terms of its effect, and selected patients with EGPA would benefit from rituximab. Kidney transplantation is safe in ANCA-associated vasculitis. This is a key message. Debate is ongoing in terms of 6 months, 12 months, but the KDIGO more than 6 months is going to be okay for transplantation. These patients, however, they would have higher mortality and particularly coming from infections early in the post-transplant course. So you just need to be careful about that. There is no need to use azathioprine-based immune suppression in these patients for their transplant. MMF will be better, because if you use azathioprine, there's been some studies that done that, and then that led to higher risk of rejection. So MMF is perfectly fine. So once you more than 6 months of remission is good enough to proceed. But the timing still debatable, whether some would advocate 12 months versus 6 months. And when to stop treatment, we don't know. I don't think anyone does, but usually we would go for 2 to 4 years. So 4 years is better than 2 years. That's from the REMAIN trial, in which patients who stopped treatment early would have higher chance of relapse, and they would have a higher chance of kidney impairment, reaching end-stage kidney disease. So better to extend it to 4 years. Whenever you contemplate withdrawal, please take your time to discuss with the patient in details and have a strategy of close monitoring, because relapses, when they occur, they are unannounced and they can be bad. So regular monitoring is important. You can use the phenotype of the patient, the presence of ENT disease, the features of whether it's PR3 ANCA, rise in ANCA titers, these things. But from the kidney point of view, I find that there is no replacement for that. Regular urinalysis tell me, is microscopic hematuria back again? If it's back again, then the patient is in trouble, because that's most likely, if it's unexplained by anything else, such as infection, then that's relapse happening. So close monitoring is important for these patients. And how to stop? Be slow. Do not stop suddenly, and give it 3 to 6 months. The REMAIN trial was very slowly tapering steroids, withdrawing azathioprine. Generally speaking, azathioprine beyond the 1 year, you can reduce. You don't need the high dose azathioprine beyond 1 year, but in selected patients, so not one size fits all. So that's ANCA. What about anti-GBM? So anti-GBM is usually a single hit, as we learned it. Also, we'll find out that we also have atypical forms of anti-GBM. The main things that I wanted to discuss is who should be treated in patients with anti-GBM disease, because sometimes treatment might be held or not provided in certain settings. So here we have a 64-year-old lady who attended a district hospital, suspected pyelonephritis, with a creatinine of 260, baseline was 50, no significant past medical history. Urine culture has been negative, but she was given antibiotics for suspected pyelonephritis. And no improvement. In fact, it's deterioration, progressive decline in the kidney function. And then she's transferred to a center, and she's got refractory hyperkalemia, severe metabolic acidosis, and she has frank hematuria. Maybe this was confused at the beginning with the pyelonephritis. But anyway, this is your first time you're meeting her. And then an immunology screen immediately sent, and we got results back same day that we've got anti-GBM of 340. The complicating factor here is that the patient is a Jehovah's Witness. So doing kidney biopsy is not as straightforward here. So you start plasma exchange, and patient needs dialysis. So aggressive treatment is started here. So who should we treat? In this patient, we don't have a kidney biopsy, but if we have a kidney biopsy, because she refused to give them, so we just treated the patient. Because of chance of recovery is there. Does starting dialysis means there is no chance of recovery? Does having a creatinine of certain figure would mean that there is no recovery? So Silkebrix and colleagues looked at this in a large sample of patients with anti-GBM disease, and the findings is that you can categorize based on the presence of RRT or presence and the presence of normal glomeruli. If you have less than 10% of normal glomeruli and you are on renal replacement therapy, then the chance of recovery of kidney function is quite slim. But if you have more than 10% of and you are on renal replacement therapy, still you have a chance of recovery in this setting. So therefore, having a kidney biopsy in these patients is very, very useful tool to have, and it would guide your treatment plan accordingly, rather than refusing the treatment in all patients. Anyway, the patients that I mentioned there earlier on has recovered with a treatment plan that included plasma exchange, cyclophosphamide, and she recovered from dialysis. So what about a typical anti-GBM? Sometimes we do biopsies, we find it is linear IgG deposition along glomerular basement membrane, but we don't have anti-GBM antibodies. This is what's referred to as atypical anti-GBM. The reason behind this is not entirely clear, but they tend to be less aggressive rather than the classic anti-GBM disease. They don't have, even on biopsies, they don't have significant degree of rapid progression. They would be a bit more subtle. Lung hemorrhage tends to be much less compared to the classic anti-GBM disease. And the response to treatment is a bit better. One of the reasons for this heterogeneity in anti-GBM is that the target for the anti-glomerular basement membrane is a bit different in these patients from those with classic anti-GBM. As you know, the NC1 domain of alpha-3 chain of the type 4 collagen is the classical target for anti-GBM disease, but these patients is targeting other areas of the NC1 domain, or sometimes not IgG, it's an IgA or different patterns. So typically the anti-GBM is negative. Another scenario when we have anti-GBM is when we have membranous nephropathy. So in this patient who presented with, she had a history of multiple sclerosis with fatigue and developed hematuria with rapid deterioration in kidney function, so RPGN pattern. She was NK negative but anti-GBM positive, and she had crescentic glomerulonephritis, confirming IgG deposition, linear deposits on IF, but she also had podocytopathy associated with this. She was PLA2 receptor negative. So the Hammersmith group published on this topic previously, but usually patients, they would have a poor outcome when we have this combination of membranous and anti-GBM. In our patients, we just use the same protocol that Hammersmith has been using. Combination therapy is a good approach with rituximab cyclophosphamide and plasma exchange. The patient recovered at 6 months, so aggressive treatment is indicated here to salvage kidney function, and they don't tend to relapse. They tend to be more in remission when those who respond. But otherwise, if there's a deterioration, then it tends to be progressive and reach end-stage kidney disease within the first 12 to 18 months. Our patient responded well to the treatment. And the relapse, when it happens, is not, I didn't mean an anti-GBM relapse, it's more like a progression of the membranous rather than the anti-GBM disease. Kidney involvement in medium vessel vasculitis. In medium vessel, we are dealing with a different settings. We don't have often a severe GN happening, but we have different manifestations, as exemplified in this case of 44-year-old lady who presented with abdominal pain and hypertension. She has MSK features. She's got neurological insult with her foot drop. So she's got coronary perineal nerve injury, and she's got livedo reticularis. So multi-system presentation. She's hypertensive. She's got an active urine sediment, and her creatinine is 240. And she's oliguric despite volume replacement. While she's in day one of the hospitalization, she develops a PR bleed, and she gets a CT to evaluate for the etiology of the abdominal pain, and the CT showed widespread aneurysmal abnormalities. Because of the PR bleeding, she required to get an angiography to embolize the branch that was bleeding of the inferior mesenteric artery. This was her angio, and as you can see, different size of aneurysms everywhere. When it comes to the treatment of these patients, usually you would like to avoid plasma exchange as much as possible if they are hepatitis B negative. This patient was hepatitis B negative. Plasma exchange, there's no evidence that it adds a lot to the patient management, but those with GI manifestations tend to have higher mortality, and therefore cyclophosphamide would be better compared to rituximab in terms of the treatment. So the option for the treatment here would be steroids and cyclophosphamide to achieve remission. And they do relapse as well. About 30% of these patients, they relapse. So they are not like it's not a one-hit disease. So they need maintenance treatment. And again, we don't know for how long to treat. Some they would go into remission better than others. And finally, with large vessel vasculitis, we have giant cell arteritis and osteoarthritis. And this patient presented with history of autoimmune hepatitis and a near catastrophic presentation of chest pain, abdominal pain, and she was very sick at the presentation to ER. A CT angio was done. She was confused, depressing level of consciousness, and found to have absent pulses in her left arm. A CT angio showed widespread stenotic changes in both subclavian arteries, common carotid artery, and also showed absent perfusion of both kidneys. She was anuric, and she had bilateral renal artery thrombosis. She also had thrombosis of her coronary artery. CT coronary angio must to do in these situations because they can have coronary artery aneurysms as well, was negative. And confirmation later on came in with a PET CT that showed evidence of aortitis. So we have widespread large vessel abnormalities and bilateral renal artery thrombosis. How should we treat? So she was very sick, so we started steroid and cyclophosphamide. Detailed discussions with IR and vascular surgery regarding salvaging these kidneys is required because it could be possible to salvage. And there are data out there on these cases when you do either catheter thrombolysis to perfuse the renal arteries, because most of it is the stenotic element rather than the stenotic element with time might respond to treatment, but thrombosis, if you deal with that, and a secure perfusion of the kidneys might have a better outcome. Anyway, in this patient, that did not happen. So started treatment with cyclophosphamide and steroids, and things got better. She's dialysis dependent from the kidney point of view. The rest of the vasculitis things are better, and she switched to maintenance treatment with azathioprine. Now, the question arises after a year that would you transplant this patient? Would she be a candidate for transplantation? And what should we do to safeguard that the transplantation is going to be safe? And there are some technical challenges from the surgical point of view, because you have thrombosed and stenosed vessels. So an angiogram is going to help you to in multiple ways. First, to ascertain that there is no progression of the disease, no new stenotic lesions, to tell you that you are in remission. And a PET-CT, it can give you an idea about the activity as well. And her PET-CT was negative, so essentially deemed okay to move on with transplantation. Very important not to stop treatment as you are considering transplanting, because if she flares again and she's thrombosed her other iliac arteries, you'll be snookered in terms of where you're going to put that kidney in. Important not to stop the azathioprine, and yes, transplant is possible. So the conclusions here are kidney involvement is common in different vasculitides, and it takes different patterns. Very important to ensure early diagnosis so that you can get better outcome, better kidney function, lower chance of comorbidities, and happier patient as well, happier doctor as well. It's quite rewarding when you get good outcome for your patients. And then targeted and combination therapies are important in achieving that. Key message here is if we can reduce exposure to steroids safely, it's very important to achieve better outcome. Often these conditions, whether it's ANCA or anything else, is relapsing, and therefore close monitoring is required, and discussion of the treatment plan on an individual basis is required. But I understand that limitation and availability of these agents might make a special challenge for what would be the right approach. And discuss with experts. It always helps, because the strategy that we've been using in Aberdeen is always have an MDT-based approach, and to be challenged about your practice is a good thing. It's a healthy way to learn and get the best for the patient care. Thank you. If there's any questions.
Perfect. Thank you, Dana, for the fantastic presentation. I myself, and I believe everyone else, has learned a lot, and we managed to keep nearly 150 participants till the end. So that's definitely an excellent outcome. So I have a few questions from the attendees, if that's okay. I'll go through them one by one. So the first one from Dr. Haitham is, can prediction scores make rebiopsy the patient to monitor response dispensable? What are your thoughts about this?
I'm sorry, is it possible to repeat the question again?
Yes. Can prediction scores make rebiopsying the patient to monitor the response dispensable? I believe he's asking about
whether you need to biopsy. So that's a good question. The idea about the prediction score is not related to whether you rebiopsy or not. If you want to rebiopsy before withdrawal of treatment, similar to lupus settings, that some centers, they do that. Some centers, they would do periodic protocol biopsies for the patients. Might not be needed if you have followed up by simply by the urinalysis. There are new tools will be available as well. For example, the urinary CD163 is a possibility in terms of predicting relapse, or CD4 T cells. These are experimental tools, but gradually they would be filtered into clinical practice, leaving the rebiopsy need for ANCA settings, at least, perhaps not as strong as in lupus settings. Lupus would be absolutely, can't have enough biopsies in lupus settings compared to ANCA.
Absolutely. Yeah. I have another question, Dr. Plan. Thank you, Dr. Kader. What about induction regimen? Open bracket 3 pulse methyl bread, or just 1 pulse, and a question mark 250 or 500 milligrams? I believe we usually go for 500 to 1 gram. Do you have any other thoughts about this, Dana?
Yes, so there is some recent observational studies coming out. It's not randomized, but using a lower dose of pulse steroid of the 250. Excellent point. So yes, it is possible, especially if you have your hands on avacopan. And that would make it even more straightforward. You don't need to go for high doses of steroids, because avacopan is likely to help you in that regard. When it comes to the pulse of steroids, it's not always needed to pulse with steroids. You can just use oral steroids at the beginning. The pulse steroid would reduce the intrarenal inflammation very quickly for you. So that's the appeal of the pulse of steroids. But oral steroids can be okay as well. So you might not need to use pulse steroid in every patient.
Absolutely. Again, another question from Dr. Blal. Why no complement consumption in ANCA if alternative pathway is being used?
Why no complement?
No complement consumption. I believe Dr. Blal is asking about C3 and C4, because that's what we can. But yeah.
By the way, there is some studies in this regard. When you use C5a receptor is one way of blocking the not blocking the alternative pathways. Selective in terms of only preventing the anaphylatoxin binding to C5a receptor, and therefore influx of neutrophils to the. You can go more proximal and use a factor B inhibitor. There is an ongoing trial with using eptacopan in ANCA-associated vasculitis. So you can tackle different parts of the alternative pathway. There is some evidence for also the classical pathway being involved, because some patients, they would have C3, and not only C3, C4 deposition as well. So the reason the alternative pathway has been considered is the fact that it was very successful. That does not mean we'd have no other parts of the complements that are not we can't tackle, but generally speaking, more proximal complement inhibition rather than distal would be the way forward. I'm not aware, however, of any classical pathway targeting and trial levels for ANCA vasculitis.
Thank you. We have another few questions. We do not have a avacopan. Can we use a combination therapy as a steroid sparing method?
Yeah, so this is another good question. So Stephen McAdoo and the Hammersmith group, that was before avacopan was available. The combination therapy was used exactly for this purpose, so that you can achieve lower dose of steroid exposure and even steroid withdrawal. And they showed good data, again, observational. You can, as you don't have avacopan. But be careful that not one size fits all. Be selective in your approach. Not every patient would need even the combination. So if you have severe presentation, then the combination therapy would be useful. It's not without its risks, and you need a good collaboration from an infusion clinic to support it, because it's multiple sessions with the treatment. Using the 4-weekly approach, like a rituximab approach, is this most straightforward way of doing it. But you can do 2 weekly as well. But the 4 weekly is the routine way of doing it.
Absolutely. In Pixivas, they did not use plasma exchange immediately after diagnosis. Do you suggest use it immediately? I believe this question was was put in at the same time you were discussing the Pixivas case, the trial and the case reflecting it. Yeah. So, but I believe that question has been explained later on with the other 2 slides later on.
So do you want me to
yeah, please, if you want to reflect.
So in terms of the timing of there is no need for immediate but especially whenever you use plasma exchange in ANCA, unless the patient has got hypoxemia or the pulmonary hemorrhage, that would be the situation when I, as soon as possible, would like to start. If it's going to be for the creatinine side of things, I will take my time, an awful amount of time with the patient actually, to explain how this might help the kidney function versus the risk of infection, catheter-related infections, etc., and just make sure that the patient is on board with that approach. I just also want to mention that when you look at the BMJ meta-analysis data, there was a patient as an author on that paper. It was a key part of that suggestion when it comes to KDIGO, or the conclusion of the meta-analysis is that patient involvement in that decision making. Would you accept 3-fold or 2.5-fold risk of infection for the sake of not being on dialysis at 1 year? Some might say yes, some might say no. So that's why individualizing the treatment is very important.
Absolutely. One more question. A dual positivity, a cyclophosphamide plus pulse, then maintain as ANCA and the plex irrespectively. I believe this was a statement when you were asking about the dual positivity. We have a few more questions. That's okay. Dr. Sajad, thank you for the excellent talk. I have one question about the efficacy of rituximab on long-term maintenance with possible risk of anti-rituximab antibodies, and if happen, what is the alternative?
Okay, so this was happening in the a long time ago, when about the worries about developing anti-rituximab or HACA antibodies, and whether using a low-dose methotrexate might reduce the chance of that. With currently the biosimilar or ones available, the chance of that is less likely. But often when the rituximab, when we say rituximab loses its effect, is not just the rituximab, but the disease is not responding anymore to rituximab, just like the case that, for example, was relapsing while on rituximab and needed more potent B-cell treatment. There are also other approaches like BLIS, BAF inhibitors that will be coming in the future in these settings. So it's not just the antibody against rituximab. But seldom we do that nowadays, checking for the antibodies, but often it means that rituximab is done its bit. You need to move on to something else.
Perfect.
I don't know if that is more likely in situations that the general consensus is that do repeated dosing, not wait and treat. The repeated dosing is higher chance of remission achieved with that. But would you continue repeated dosing beyond 36 months? That's debatable. The French Vasculitis group, they would go for more wait and treat rather than regular dosing, but the rituximab was higher dose and regular dosing. Don't wait for disease. If you're going to do that, if you're going to wait and dose, don't use ANCA, use B cells for the decision to start the treatment again. A B cell repopulation will be the timing, not waiting for the ANCA to rise again. But the biosimilars are cheaper nowadays, so it should be more straightforward for regular dosing.
Excellent. Okay, Dr. Planet asking about OP, obinutuzumab. Do we need to check immunoglobulins? End of 1 gram day 1 and then day 15?
Not immediately checking immunoglobulin, but the chance of hyperglycemia, theoretically, again, the use of obinutuzumab is in the OBIVAS trial. We are waiting for the outcome of the trial. Apart from that, is case series and selected cases like the one that I mentioned. But we tend to monitor for hyperglycemia, similar to rituximab, dose again for the 6 months. Not early on, it's not going to affect things. But before you start the treatment with obinutuzumab, if that was the question, if you want to check immunoglobulins, if they're hypogamma-globulinic, that would not be your choice using obinutuzumab, because it's going to make it worse. So we need to choose an alternative approach.
Thank you. Dr. Manal Idib is asking about rituximab plus cyclops therapy. What are the doses of them and sequentially? I believe this is just to go through the category 1. That's okay. It's well written. Ahmad Omar is asking who respond to obinutuzumab. Sorry, patient who responded already to obinutuzumab. What could be the maintenance therapy?
6 monthly. Sorry, I interrupted you.
No, please. Yeah.
So it's 6 monthly for the obinutuzumab. So you might be able to wait till 9 months. We don't know is the honest answer, but the data from hematology, from lymphomas, is similar to rituximab, and so I'm unlikely that you need to deviate from that by that much. But in our patients, usually closer to the time, we would evaluate for and if there is no concerns in terms of recurrent infections, anything like that, redose and diseases responded to the treatment, you carry on with the treatment 6 to 9 monthly.
Perfect.
Make sure the patient is on PJP prophylaxis throughout.
Yeah. I think we'll just treat it as rituximab generally at the moment.
Exactly.
And take it from there till we have more data about it in ANCA-associated vasculitis.
Yeah.
Perfect. Ahmed has another question. A patient who remained positive PR3, can they be transplanted? I will actually add a question here as well. ANCA positivity, right, or the titer has been remaining. So clinically, the patient seems to be in remission, but the titer of the ANCA remained as it is, or mild reduction. What's your statement about the transplantation and convincing the transplant team that the patient is not really in flare or in any sort of activity?
So there are two large set of data out there from last year published in KI reports and American Journal of Transplantation, as well as a meta-analysis. The short story is that the presence of ANCA positivity might increase chance of relapse, but the relapse is not significant event post-transplantation and should not put you off from the transplantation. But not every study is showing it that to be associated with that. Not every patient having a positive ANCA means that they would have a relapse post-transplantation and the relapse to be severe enough. So a positive ANCA at time of transplant doesn't mean much in terms of, because we are talking about 0.02% of patients having an event post-transplantation happening. and that event is completely treatable. ANCA positivity, and when we looked at it, we looked at the Edinburgh cohort who got transplanted. We didn't see significance in terms of the tendency to relapse. When we pulled the data that we are talking about, this is almost like 10 years ago. The meta-analysis is more up to date with lots of other studies, including the one that we did. Only when you pull it together, then the ANCA becomes a relevant factor, which means that is unlikely to be influencing outcome much. So it shouldn't be a reason to not to transplant or wait for it, because the patient will only increase more morbidity.
Perfect. Thank you. I have another question. Thank you for the excellent speech. For Wegener disease, when do you prefer to use combination of cyclophosphamide and rituximab?
In severe disease, it tends to, and whenever you want to withdraw steroids early on, if you don't have avacopan, or even if you have avacopan in severe disease, is excellent to achieve high rates of remission and it's more durable. But I wouldn't use the combination in extremely frail patients, though.
Okay, thank you. A question actually is commenting about the cost of avacopan. So yeah, it's an expensive drug, but we had a sparing drug. So I don't think we have any hands in here. So another question, if the patient end up on chronic dialysis and he had a renal limited vasculitis, do we need to keep patient on any immunosuppressive drug, or we should stop all immunosuppression? That's a good
You
question.
can stop all. If it's renal limited, you don't need to carry on, but just be careful that you screened for everything else when you're taking that decision. If it's renal limited, it does not need any form of treatment as they established on dialysis. Just be careful that you don't do that before deciding that's end stage and they did not recover. But if you decided that that's it, it's dialysis dependent, more than 3 months from presentation, then yes, everything can be withdrawn.
Another question, do you suggest using steroids with
sorry, I was just going to, I forgot one point about that patient. If you withdraw everything early on and you use rituximab at the beginning, make sure that you cover it for infection when you, so that they wouldn't have a higher chance of infection. Ideally for 3 to 6 months if you use rituximab.
Absolutely. Thank you. Another question, do you suggest to use steroids with avacopan for ANCA vasculitis, or avacopan only for patients who can able to use steroid?
So I suspect the question is, can I use avacopan alone without steroids? And if I would use steroid with avacopan, when can I withdraw the steroids? So using avacopan without steroids is yes, you can, but not every patient. I'll give you an example. If someone has got lots of ENT disease from the beginning, and you use steroids, you can't straight away withdraw it. When you look at the Advocate trial, the steroid withdrawal happened between 12 to 16 weeks, and the post-marketing data has happened between 3.5 to 10 weeks withdrawal. So that the steroid withdrawal, it is possible, whether the patient, if you withdraw it very early in the wrong context, and just rely on the avacopan, be prepared that you might need to go back in and out again with the steroids. And if a patient's having ongoing features of active disease that's not responding to the avacopan alone. And just remember that Advocate was not steroid avoidance. It was a sparing, so two patients did have some steroids. But if you have someone who's got a GI bleed while they are presenting and they've got severe GI inflammation, you can't use steroids, then of course I'll just use avacopan alone in that scenario rather than be exposing them to more steroids. Sorry, Salah, you are muted.
Sorry, clicked the wrong button. We have another question from Shekina. What is your recommendation for maintenance regimen for patient with EGPA? Would it be still PRED plus or minus Bendra?
On prednisolone and benralizumab.
Benralizumab, yeah.
We don't know about EGPA is particularly a relapsing condition. The benralizumab in context of asthma was used to reduce or prevent exposure to high steroids. In EGPA, we are waiting for the clinical trial data to come out, see in terms of how effective it is. But considering the relapsing nature of EGPA, not all patients achieve steroid-free with the benralizumab. As long as they are in remission with the benralizumab alone, you can continue with that. And in the observational data that we have on benralizumab, it's not being used solely as a main therapy. You can also use it in combination with mycophenolate or methotrexate, but not with rituximab, but not come across that. But you can have additionals if you have disease activity. And then tezepelumab is under investigation for better control if benralizumab fails. That's another option.
You have a couple of more questions. How long we need to wait for renal transplantation once the patient with ANCA limited vasculitis? I assume renal ANCA limited, but it's not really written within the question.
Regardless of it's renal limited or not limited, is achieving remission for 6 months or more. If they are dialysis dependent in 6 months or more, then can be considered for transplantation.
And another question, and how would you define a remission? That's okay.
Remission, renal. So you define the standard way of doing that through assessing a BVAS scoring. And if they would not score, for example, in renal, you should not have any hematuria. We shouldn't have any worsening creatinine from baseline, no new onset hypertension, and proteinuria that is stable and is not rising. So you standardize scoring that you would do for achieving remission. In clinical practice, we rely on stability of kidney profile, lack of hematuria as for the kidney remission. If you are in doubt, biopsy.
Good. Imaging?
Pardon?
Imaging?
Imaging, limited in terms of the validity of that approach, in terms of whether doing PET CTs in these scenarios, whether it's going to give information. There are some reports on that. But mind you that we can also use tracers. That would be one way of optimizing the imaging, for example, an MCP-based tracing. A better way I would be a bit biased towards would be to do urinary markers such as CD4 T cells or MCP creatinine or CD163. These would be options for as in like a liquid biopsy, let's say.
Yeah. One final question. Is there any benefit of ANCA immunofluorescence staining in renal histopathology, especially for distinguishing between primary and infection-related secondary vasculitis?
Not testing for if you stain in histology, if you try to stain for MPO or PR3 is very non-specific because especially when you are dealing with an infection, because remember the MPO, if you have nets, the neutrophil extracellular traps that the neutrophils are expelling is full of MPO. So it will be positive. So if you have any neutrophil-based inflammatory process, it will be positive for MPO. So it's not going to give you that distinction between primary or secondary vasculitic disorder. Typically in a vasculitic of infection related, it will be more immune complex base. You'll have IgG, IgM-C3. So it's immune complex deposition would be there. Although you can have a situation, for example, you have an MPG and like pattern, but it's easier to define that based on the morphology compared to an ANCA process.
Excellent. I think that's all for the question for today. Thank you very much, Dana, for your attendance today. We have lots of thank you in the Q&A section, and I keep receiving lots of messages. Thank you as well for this fantastic talk. We learned a lot today, and thank you for your presence.
Pleasure. Thank you very much.
Thank
Bye-bye.
you. Bye.